Anyway, welcome to our special Grand Rounds lecture today. And we're delighted to welcome somebody who's very special indeed in many ways. I'll just give a brief introduction, but we're welcoming Dr. Israel Jacobowitz, professor of surgery at SUNY Downstate Medical School, who is a cardiothoracic surgeon. So we don't often have cardiothoracic surgeons giving us grand rounds. We have, of course, in the past, but not often. So this is special. And his topic is even more interesting because it's a surgeon teaching us about atrial fibrillation, or a combined program of atrial fibrillation, ablation, both from a surgical point of view, along with atrial clipping or ligation of the atrial appendage, and combined with EP-related ablation as well. So endocardial and epicardial ablation, and a combined procedure that he'll talk to us much more about. Dr. Jacobowitz is a good friend of Dr. Corn, whose parents somehow introduced each other, and it's a long story, but goes way back. And he's also a friend of Michael Rosenblum, who trained with him at NYU. So he's really connected very well here at Cooper, and we had a chance to meet last night, and it's a pleasure to welcome Dr. Jacobowitz. He is, as stated, went to medical school at SUNY Buffalo. He did his CT surgery training at NYU, where he met and helped to train Dr. Rosenblum. He was trained by the great Frank Spencer, and he's been practicing for quite a few years. I'll let him tell you how many, but it's multiple decades, let's put it that way. So we're delighted to welcome him. I think Dr. Russo might want to say a few words as well, so I'll turn it over to her and we'll get started with the program.
Yeah, no, I'd like to, first of all, thank you for coming and sharing your expertise here. We've been working on, developing a collaborative program related to atrial fibrillation, all the different aspects of, atrial fibrillation. It's really a systemic disease, right? It affects everything, and having, both the kind of preventive side of things and then the higher level treatment for patients who maybe aren't the most appropriate for an endocardial ablation procedure all the time, or have had an endocardial procedure and now need something else. So we really welcome having really the whole spectrum of treatment for this arrhythmia, and a collaborative integrated care approach for treatment of AFib. So thank you so much for coming, and look forward to having you share your expertise with us and lots of experience in this particular arena. Thank you.
Well, thank you for having me here. It's a pleasure to be here for multiple reasons. I think particularly today in medicine, having collaborative effort has been demonstrated to be of tremendous benefit to patients and the team approach. And I think it's always a lot more fun to be working in a team-oriented atmosphere. I hope I can do justice to the medical component of atrial fibrillation. I try to educate myself as much as I can about that. I'm always fascinated. I walk into the lab and see all those colors and the mapping systems. I'm totally lost, but nevertheless, it's great to collaborate and work with who I think are very, very bright people in this complex field. So we'll get started. And we're going to talk mostly about persistent atrial fibrillation. So it's a matter of looking at the patient population, the need for advanced therapy, the basics of hybrid AFib ablation, and the recent trial that was published, and that the FDA approved the catheter as actually the only catheter out there for epicardial ablation for long-standing persistent atrial fibrillation. So the patients are complex. They have symptoms. It's a societal burden, quality issues with regard to their performance. So it's the substrate's about 8 million patients in this country. I've seen it as high as 12, but it's growing as the population is getting older. Particularly the patients over 75 and 80 have a quite substantial incidence of atrial fibrillation. Approximately 45% of that patient population is the persistent long-standing atrial fibrillation, where we presently don't have a good answer for treatment. The symptoms vary: shortness of breath, dizziness, weakness, fatigue, blood pressure, pain, or pressure in the chest, rapid irregular heartbeat. I find that particularly these patients, which isn't listed here, but my impression has been that particularly associated with these bouts of rapid heart rhythm, there's tremendous anxiety. I find these patients to have, are tremendously anxious about those episodic occurrences, rapid heart rhythms. It's a burden as far as the patient's visits to doctors. 40% of these patients report a reduction in their quality of life. They have multiple out-visit patients, emergency room visits, et cetera, that impact on their quality. I was struck by this when I first saw it. It was hard to fathom, but the mortality for patients in atrial fibrillation in the Medicare population over 65 years of age is higher than it is for many malignancies. And it certainly doesn't receive the kind of attention that we see publicized about these other malignancies where the results of the treatment are far better than they are for atrial fibrillation. I think one of the things that go along with this whole AFib program treatment is patient education, physician education, and awareness about the morbidity and mortality associated with this disease. It's a growing problem. As I said, it'll be 12 million people by 2030. That's in the United States alone. It's over 30 million around the world. Tremendous cost of, it says 8,700 on this particular slide, but I've seen it as high as 12,000 per patient. Multiple stresses on the system with ED admissions and hospitalizations, and overall cost of $26 billion. The clinical need for advanced therapy. So we'll see what's out there now. Catheter ablation has been around for 20 years at least. Despite advances of mapping systems and different types of technology, whether it's rotors, whether it's ganglion blockers, whether it's using cryo, whether it's using radio frequency, et cetera, the results are still relatively poor in this group of patients, and certainly affected adversely by the size of the atrium and by the time length that they've been in atrial fibrillation. Atrial ablation can be offered to patients with long-standing persistent, but as you'll see, the results with catheter ablation alone have been pretty dismal. They are affected by other comorbidities. Sleep apnea is a significant factor. Severe obesity is a significant factor, and increasing age and left atrial size, because these things have an impact on fibrosis and structural changes within the heart that adversely affect the ability to get good results with endocardial ablative technology. So this is a progression from paroxysmal, persistent, long-standing. As you see, the majority of the patients are in the long-standing, persistent group. And with that, there's a changes in the triggers that promote atrial fibrillation from those that are principally around the pulmonary veins to those non-pulmonary vein triggers in the various substrates that then create this re-entrant mechanism, cycles of AFib begetting AFib, and having a more difficult, challenging spectrum to treat. So PVI isolates less than 50% of the triggers, and it interrupts 0% of the drivers for atrial fibrillation. And this is some of the mechanism that goes on while pulmonary vein triggers are predominant early in atrial fibrillation. There's an increased involvement of the atrium itself, and as disease progresses, this mechanical stress on the atrium and stretches that occur further lead to fibrosis and ultimately atrial fibrillation. Epicardial fat plays a role in this as well. Surprisingly, actually, and it's interesting as I think about this open surgical approach and what we do, it makes a lot of sense as to why some of those results with the MACE procedure are so good, because we do attack the fat as as well. And then there's the ganglionic plexi that are involved in atrial fibrillation. So the various techniques that have been used, or pulmonary vein isolation, appears not to be enough. And then there's the expanding role of the posterior wall, various lines, various triggers in the superior vena cava, coronary sinus, rotors, left atrial appendage, and ligament of Marshall. This on the left here is the graph from the Hamburg study, which shows the results of 5-year outcomes. The lower curve is the curve with single procedure that was performed, and as you can tell, it's pretty dismal, both early and only gets worse. And these are the results with multiple ablative procedures. This is looking at the various studies that were done, regardless of whether they had lines added or they had other ganglionic blockers, etc. You can still see that with single procedure, the results come out to about 43% at 1 year. So in spite of the fact that other substrates are attacked, nevertheless, the results seem to be poor. And here again is a graph showing the pulmonary vein isolation alone, adding electrograms, adding lines, and you still see that there's a quite substantial decline after the initial blanking period. These are the structures involved with the atrial fibrillation. You have the autonomic ganglions here, which are depicted in yellow, including the ligament of Marshall. And you have the small and larger wavelets that further are involved in the prolongation of atrial fibrillation. The red represents the pulmonary vein triggers, and the green are the various triggers throughout mostly the posterior wall, as well as in the SVC and coronary sinus. And then you see a combination of all of these triggers involved with atrial fibrillation. And as you can see, most of them are located within the posterior wall of the left atrium. Anatomically and embryologically, the left atrium extends into the pulmonary veins. But there are other sites, as I said, the rotor activities and plexi that are involved in atrial fibrillation, particularly in long-standing persistent atrial fibrillation. And while it's been shown that it's feasible to isolate that, and in spite of the fact that you isolate that, the patient still return into atrial fibrillation. So isolation may not be the same, and doesn't appear to be the same as transmurality. And in addition, you have the limitation of the esophagus, which is nearby, and there's certainly a substantial concern as far as the sequelae of injuring the esophagus from a posterior endocardial ablation. These again, various different studies that use various different studies in using lines and boxes for both persistent atrial fibrillation, paroxysmal atrial fibrillation, and you can see that the results are just all over the map. There's no reproducibility with regarding to any of these results. And in some of these studies, there was substantial incidence of, particularly this one here, the incidence of pulmonary, of esophageal injury, major injury was 0.5%. This is some of the mechanism involved with it. And what you see here on the far left side, the structural changes that go on. On the right here is the anterior wall of the left atrium. On the left is the posterior wall of the left atrium. Here, there's no structural heart disease. Here's structural heart disease, paroxysmal AFib, and progression when you have persistent long-standing atrial fibrillation as to the nature of the fibrosis that goes on in the posterior wall of the left atrium. The other concept that's been introduced is a dissociation between the epicardium and endocardium that occurs, both secondary to the thickness and fibrosis, as well as the interposing of fat between the epicardium and endocardium that makes it very difficult to be able to get transmurality achieved. This shows the differences within the posterior left wall, between the posterior wall of the left atrium as you move around the entire wall depending on its location. So this is up in the dome, which seems to be the thickest and is interposed again with adipose tissue between the endocardium and epicardial layers. And it's a further impediment to be able to get transmurality achieved. This depicts that while you have isolation on the endocardial surface of the heart, the epicardium shows that there's a fair amount of activity. So again, while you may see initial isolation, it quickly fails because of the fact that transmurality hasn't been achieved. And this again is just the same as this one that I showed before with the structural heart disease and the progression. And again, you can see that the fibrosis is mostly located in the posterior wall of the left atrium. This again just shows complex fibers, all of which are involved with different thickness. And this is done by MRI imaging. Beyond my sophistication as to exactly, but it just showed, but I think is involved with the high recurrence rates and the complexity within the posterior wall of the left atrium and throughout the left atrium, including the left atrial appendage and the ridges there and the thickness and variation in the walls of the left atrium. Here we see the relationship of the left atrium to the esophagus and the lymph nodes and arteries and vessels that are related between the left atrium and the esophagus, and all of those things can get affected, including the vagus nerve, and therefore have motility issues that are associated with the with burning the endocardium and directing the energy posteriorly. Most of these fortunately resolved, and they're not of prolonged limitation, but nevertheless do cause issues with regard to various symptoms associated with injury to both the esophagus, the plexi around it, and the blood vessels. And we can see that there's various levels of injury to very superficial that are hardly symptomatic, to ones where you could develop a deep, greater ulceration, and we certainly know that when there's perforation of the esophagus, mortality associated with that is prohibitive. Here we see the various results depending on when you affect the ablative process on atrial fibrillation, and that if you act within the first 2 years, your results are far better than with multiple procedures after the 2-year time frame. And I think this goes hand in hand with the European study that was recently published that showed that there's major benefit of ablative treatment of atrial fibrillation early on, and that it leads to much less morbidity and mortality as time progresses. So we have a situation with high recurrence rate, concern for fistulas, fibrosis, fat bundles, unique epicardial structures where we're not able to achieve transmurality, dual layers, and epi-endocardial disassociation, all of which limit the effectiveness of an endocardial-only approach, which leads us to the concept of a hybrid AFib approach, where we attack the problem of both an epicardial and an endocardial surface. Surgical treatment of atrial fibrillation has been around since the 1980s. We know that there's great success in publications from the Cox-Maze procedure, which initially started out as a cut and sew complicated procedure, not without its potential complications for bleeding, pacemaker requirements, etc., but nevertheless very successful in returning patients to sinus rhythm. But I have to say, in 42 years of practice, I've had patients sent to me for a Cox-Maze procedure only, not concomitant with other procedures, twice in patients who had the thrombi in the left atrial appendage and couldn't tolerate anticoagulation. There are certain centers that have more robust practices, but that's really rare in this country. So physicians are generally loath, and patients are generally loath to go ahead and have this procedure done. And I think it also goes hand in hand with sometimes a lack of appreciation as to the severity of the consequences of long-standing persistent atrial fibrillation. So the convergent approach has the surgical component is really relatively simple. It's like draining a pericardial effusion. So you make a small incision, subxiphoid, go into the pericardium, and you visualize the posterior wall of the left atrium, and you do your ablation. It takes 90 seconds. And then you have the electrophysiologist component, where they go ahead and check and test to see what's active, where there's fibrosis, and determine the lesions that need to be made. It's usually completion of the pulmonary veins, and in our experience, we've added a few lines depending on what we find. So that I'll show you our experience as I go on. So this is the catheter. That's the EpiSense catheter. You can visualize the burns as well as get an electrogram to see that the voltage has changed. And this is the endocardial completion of the procedure done in the usual fashion. It's a subxiphoid. It's a cannula that's inserted, and a scope, 5mm scope, is introduced, as well as this EpiSense catheter. This is the scope. I don't know how many of you can remember the old sigmoidoscope, but when I was a resident, you didn't take a patient for colon surgery without taking the patient for a rigid sigmoidoscopy. And while this isn't quite the metal one, but it reminded me always when I use it that it looked exactly like a sigmoidoscope. But it is translucent. It has a wire here, and it's hooked up to irrigating fluid and suction. So the way it works is you irrigate through here, and then you suck the fluid out. So it's a irrigated system when you do the ablation. This is the catheter itself, which is a unipolar radiofrequency ablation catheter. And it has suction, and it has these dots on here. And the reason for that is so that we know we're oriented and up against the heart and not facing posteriorly towards the esophagus. I never really understood this. When this was first introduced, it was introduced with the ablations being performed over the wire. So there's a wire that goes through this introducer, and I've used it from time to time. I find it helpful to give some rigidity, but for whatever reason, when this was first done by Edgerton and Natalie's group down in Dallas, they had a very high morbidity and mortality associated with this procedure, which I've never really understood as to why. But basically, most of the time, we don't use that wire. The introducer hasn't been changed because it has to go through a whole FDA approval process, so we kind of ignore the fact that's there, but use the wire to be able to position the catheter anteriorly or posteriorly to the wire, which helps in getting these positioning appropriately to complete the ablation procedure. Also, when we first started doing this, I started in 2012 to 2016, we were doing it trans-abdominally and going transdiaphragmatically. And now it's all done subxiphoid, so that the abdominal cavity is not entered at all. And these are the lesions that you clearly visualize when you're performing the procedure. And there are various, epicardial endocardial lesions that are made. A lot depends on exactly what the map shows as far as inducibility of AFib or aflutter. But the routine that we've used is completion of the pulmonary vein isolation and the cavo-tricuspid line, and everything else depends on what we find. So sometimes there's a dome, sometimes there's the mitral isthmus line. very, very rarely coronary sinus. There's coronary sinus ablation. Then there's left atrial appendage management. So somewhere along the course of atrial fibrillation, doing it subxiphoid, the development of a catheter that could be readily done through a thoracoscope was developed. So we were able to add the closure of the atrial appendage to that. And this is the AtriCure clip that's used both in open cases and thoracoscopically. This depicts four, usually, I don't think I've ever used the fourth port, but there are 3 ports, 5 millimeter, 5 millimeter, and 12 millimeter. So they're pretty small ports that we access, clip the appendage, and the appendage essentially disappears. This is the positioning of the port access. So I already have a port in the fourth intercostal space. We visualize the port that's usually in the second or third intercostal space anteriorly between the mid-clavicular and anterior axillary line. And we visualize the sixth interspace port and open up the pericardium with a cautery. I usually use this hook cautery. What I do, we didn't do that here. This is one of my first cases, actually. You'll see where I think I did the appendage on the ligament of Marshall as well here. But since that time, I inject saline into the pericardial cavity. So it gives me a buffer between the pericardium and the heart, which adds an element of safety. The ligament of Marshall snuck up there for a second, but I'll show it to you in a moment. And on this case, I did not divide it, I clipped it. That's the ligament of Marshall there. Goes from the pulmonary vein up the innominate vein. And here I'm placing what's called a Pro-V clip. So there are 2 different kind of clips. This one is the open-ended clip. And then there's the Pro-2, which is the cage, which is the one I usually use most. And this is just the Pro-2, just to show you the different type of cages. I particularly like this one because I know I have the whole appendage engaged. Occasionally, when we haven't quite gotten it down to the base, I'll put the Pro-V below that. It gives us, because it is accessible through that route. So if we've completed the procedure and we see that further TE examination, that there is a space below here, you can fit a clip below that. And this is the transesophageal echocardiogram. This is before and after the placement of the clip. When we place the clip, we obviously look at the EKG, make sure there are no changes. The circumflex is right nearby. The TEE can also visualize the circumflex. We make sure that before we release the clip, that there are no electrocardiographic changes of ischemia. So this is a study that was done in concomitant surgery with the appendage clip and bypass grafting or other surgical procedures. The LAOS 3 trial, which showed that there was a significant reduction in morbidity associated with the placement of the clip compared to those patients where the appendage was not treated with atrial fibrillation. This is just a diagrammatic representation and pictures of the ligament of Marshall. And this is a situation where I divided the ligament of Marshall. I used the cautery here. So just for structure, there's the pulmonary vein. This left atrial appendage is being pushed aside by this thing called a kitna, which is a long Q-tip, basically. I don't use any clamps or anything. The appendage can be very fragile. And the ligament of Marshall has been divided. So my and this opens up another access point, which I think could be very important in getting even better results with the hybrid approach, which is you can get through the transverse sinus here and do a lesion set on the dome of the left atrium. This was our first 100 cases at St. Mary's Medical Center, which shows the results with and without antiarrhythmic agents over a period of time. And you can see that they're, actually quite satisfactory when you compare this to other studies that are out there. So the STAR AFib at 1 year is significantly less as far as being able to maintain sinus rhythm. We have the Afghanistan study, which again shows inferior results. Hamburg at 1 year. This is the Gaeta study at 2 years. This is Hamburg at 2 years. And the Gaeta study again at 3 years. And you can see the superiority of at least in our experience. And this is not randomized, this is just a retrospective analysis of our patients. And here's the overlap with the Cox-Maze 4 procedure. And you can see that the outcomes are pretty similar. Now this is our group of patients, mean age is 62, BMI is 35.3. And when you compare it to the STAR AFib 2 group, you can see that the time from onset of atrial fibrillation is longer. The complexity of the patient with regard to CHAD score is more severe, as well as some of the other parameters that we looked at. So we certainly had a sicker substrate to work with, but had better results. So these are the first 100 patients. This is the set of lesions that were performed. The blue represents the epicardial and red represents the endocardial. You'll see there's some progression as we move up the ladder of endocardial lesions that were performed. And then the last, the top group there is the group in purple where we added the appendage. I wish I had data that looks at what the results are with the combination of all three, the Bain Marshall, the appendage closure, and the ablation. I don't have that. I think by now we've had a total of about 250 cases. And this is looking at the long-standing persistent atrial fibrillation group. This was presented at the meeting in Venice. And you can see that the patients with the clip actually have very similar as far as age is concerned. The duration of atrial fibrillation is a little longer, 6.4 compared to 4.1. And the incidence of mitral regurgitation, the mild and moderate, is more significant than it is without the atrial clip. And nevertheless, the results show the convergent plus atrial clip versus convergent without atrial clip. This is off any antiarrhythmic therapy after the blanking period. And then this is taken out, out to 3 years, where we maintain very satisfactory results for this convergent group with the atrial clip. This takes us to the randomized prospective trial that was conducted. This is the patient population and eligibility. The randomization was 2 to 1 for the convergent versus epicardial ablation. Ages 18 to 80. AFib was defined by the Heart Rhythm Society definition as by 2012 as far as persistent atrial fibrillation, etc. The size of the left atrium was limited to less than 6 centimeters. Ejection fraction was, I believe, 40%. Yes, had to be over 40%. And the patient had to be refractory or intolerant of antiarrhythmic drugs, class 1 and 3. There was a history of previous CVA or TIA, they were excluded from the study. If they had any acute coronary events within 90 days, they were excluded from the study as well. 12-month follow-up was performed. These are the follow-up studies, echocardiogram, and then Holter monitors, 7-day Holters, by 18-month follow-up, and continuing follow-up for 2 to 5 years. This is a comparison of the patients, the demographics, the size of the left atrium, the length of time that they were in atrial fibrillation, and you can see that it's a matched group. Obviously, the long-standing persistent atrial fibrillation patient was the longer period of time from onset than the entire group of patients. So this is a subset that was looked at as well, specifically for the long-standing persistent group. 12 months outcomes, the freedom from atrial arrhythmia without any antiarrhythmic agents, freedom without changing any of the antiarrhythmic agents, absent or no increase in treatment of atrial fibrillation, and this is regardless of antiarrhythmic therapy. And you can see that differential, which is quite substantial between the hybrid approach and the endocardial approach, holds out throughout the 18-month period and reached significance over that time as well. This is a freedom from AFib burden of greater than 90%. And once again, one can see dramatic differences between the two groups. And this is freedom from cardioversion at 12 months. 71% of the hybrid group did not get cardioverted versus 41% of patients who underwent endocardial ablation. And these are their symptoms and quality of life performances, which are improved compared to baseline and compared to the endocardial group. Primary safety measures were met. I think that they had to be below 12%. And within while this wasn't part of the study, it was 2.9% early and 7.8% at 30 days. There were no deaths, there were no perforations, there were no fistulas. There was one stroke that did not have any debilitating effects and resolved. One temporary phrenic nerve injury. Now, again, these did not include any treatment of the atrial appendage. This is purely a convergent procedure that started out initially transdiaphragmatically and progressed to transferring to the subxiphoid approach. So this group includes the transdiaphragmatic approach as well. Major comorbidities were similar in both groups of patients: hypertension, valvular heart disease. These are studies that were in line with the Converge, or were not part of the Converge trial themselves, which showed a safety ratio of 5.8% in this group. This is a safety measure. This is long-standing persistent atrial fibrillation, and the results, these are two comparative patient groups where there's 60.5% versus 25.6%, regardless of antiarrhythmics. So they didn't report on that. They had 70% success at almost, I guess, anywhere between 12 months to 22 months. This shows some other various studies that shows lists the morbidity associated with their procedures. This patient here had a stroke, but you'll see the CHAD score was over 4. The patient had a BMI that was very high and had Test score was 4, the BMI was 39, he had sleep apnea, and had a history of a previous stroke. Was obviously a high risk patient for further complications. These are overall comparisons from the literature that are published compared to the 2017 Heart Rhythm Society reports. And as you can see, these are all in line with the findings by endocardial approach compared to a hybrid approach. So we have improved results from this combined approach. It is a collaborative effort with EP. Sometimes the patients, in our experience, have been referred to surgery, and we embrace the electrophysiologist to consult and see the patient and see which is the best method that we could apply for the particular patient. We have to establish protocols as far as trying to standardize the approach, certainly within each institution. I think it's imperative for the surgeon to look at the maps and speak with the EP so they get the feedback. And it's important for the surgeon to speak to them. I'll certainly communicate with the EP and tell them, this was challenging. I couldn't reach a certain area. You have to particularly take a look. And if we know pericardial reflections change, they differ from patient to patient. It's not one uniform. Sometimes the sometimes the spine can be challenging. It's very prominent and push the catheter from side to side. And you don't want to end up with a butterfly wedge appearance to your map. In those situations, I particularly find the wire to be very useful because it stiffens the catheter and I can position it more readily. But again, it's important to speak to the EP and let them know where things stand. So that's basically it. Any questions?
Really great. I just want to make some comments. That was, great. Overall, it's actually, I love the pictures that you included in there. And just a couple things to just clarify. So these are patients with long-standing persistent AF just for a year or more, where atrial remodeling is really started to happen. And so these are people who are more resistant. The whole push in EP now in AFib ablation is to get people when they're still paroxysmal, get them early treatment of AFib, and you showed data less than 2 years, but even less than 1 year, to get them before they have that remodeling. The other thing is people may look at some of that and say, well, it's still 70%, but the definition, so those Kaplan-Meier curves are time to first recurrence, and the HRS definition, which is I think absurd, of recurrence is 30 seconds or more of AFib. So theoretically, maybe they had more, but than 30 seconds. But you can imagine if someone has long-standing persistent AFib is in it all the time, and now you have a 1 hour episode once every few months. I mean, that to me is a success, but we would count it as a failure. And so I think we need to be careful thinking like, people look at that and they may say it's still not 100% or 98% like we say with other ablation, but that these are really success for the patients. And now we can even quantify AFib, and we did, actually Mike had done one, convergent here, and you could see all this AFib and all this AFib initially is all this irritation stuff, and then no AFib.
That's why I think it's important to also focus on the less than 90% burden, so that while we may not have, more than 75% success in getting sinus rhythm, we're definitely debulking and making the incidence of atrial fibrillation for that particular patient much less and more controllable.
Yeah, and I hope we change that definition because I think 30 seconds is absurd. It's really. But that was great, and so it really is a great addition to a program for comprehensive care for atrial fibrillation to include the whole spectrum. I'm sure other people have questions.
So who would you recommend this procedure for? Anybody and everybody with AFib, or?
Well, I can give you my bias in that, but no. I think that the paroxysmal patient probably should still continue with catheter ablation. If they fail catheter ablation, I think they should be strong consideration to this approach, particularly if the left atrium is enlarged. We've certainly done patients who have paroxysmal AFib, who've had failures from catheter ablation.
But you're still talking about symptomatic patients.
I'm talking about symptomatic patients. Well, yeah. You know, I think that's one of the problems is picking up asymptomatic patients who then progress to a point of irreversibility of being very challenging. And I think, you know, symptoms become challenging. I was saying this yesterday. There was a cardiologist who I knew for 40 years, and he had atrial fibrillation. And he came to have the procedure done. And when he came to me, he said, "I feel great. But I really don't want to be on anticoagulation." So he made it sound like he's asymptomatic, and he wants his appendage closed so he can get off anticoagulation. So okay, we said whatever you want. We did the procedure, and he comes back for a post-op visit and tells me how much better he feels. I said, "Well, wait a second." And I think that you know, people they get older, they get into denial, they think it's a progression of age and not something, and we see this classically with aortic stenosis, and I think that happens here as well. Now, obviously, there's the patient who is, you know, terribly burdened by AFib to the point that they can't, they have easy fatigability, they have, you know, these rapid palpitations that drive them crazy, etc. But then there's the other patient whose heart rhythm is not, you know, all that fast, you know, thinks they're okay. So I'm not sure how to answer that question. We know it's a progressive disease. So do you do a patient that tells you it's asymptomatic, but who's been in persistent atrial fibrillation, left atrium is getting bigger, and say, well, you better act out because what's the other sequelae? Is mitral insufficiency. It's not unusual to see this accompanied. I mean, I've seen a number of patients send to me high-grade AFib and take a look, and I say, "Excuse me, need your mitral valve attacked." And interestingly enough, I think that's a population of patients that the valve patients who are undergoing endovascular procedures now for aortic stenosis. I think there was just an article, I haven't read it yet, but I know it was in, I think it was in JAC or in Surgical Society, talking about that maybe we should take a more aggressive approach with surgical aortic valve replacement, and to address the atrial fibrillation as well. Because we know that even particularly in that group of patients, atrial fibrillation is a big issue. And my answer is, why not approach it from a hybrid approach and still do catheter-based valve replacement? I think that's an option to consider. And there's a huge group of patients with that.
I also noticed that you excluded people under the age of 75 or 80 in the trial.
That was in the trial.
Yeah.
I think the oldest said it was 84.
Okay.
Who did well, and I've not been limiting it as far as ejection fraction is concerned. So I've certainly done a fair number of patients with EFs that were below 40%, certainly. And in fact, I had a discussion about a patient with an EF of 20% with the medical director of the company who didn't want me to do the ablation. I ended up doing it. He did okay. We chose not to put a clip on the appendage of that patient after a lengthy discussion because of concern about heart failure. But I think retrospectively, you know, it increases diuretics for a period of time to accommodate for that. Because I think closing the appendage is important in these patients for not just the ablative part, but getting rid of the potential for clot.
I have a question. If the patient has had a prior open chest for whatever reason, lung surgery or perhaps cardiac surgery, can they be a candidate, or is that an absolute exclusion?
Well, you know, I would not exclude someone who's had an aortic valve done from exploring the possibility of doing it. I wouldn't be keen on doing somebody who's had coronary bypass grafting, particularly if they've had grafts placed posterior to the heart on the right side, you know, or circumflex. I probably, you know, would not do the thoracoscopic appendage closure. though I have seen video very nicely done with the mammary in place and somebody dissecting it out and doing the appendage closure in that group of patients and doing a hybrid case. Having said that, as a general rule, I would stay away from those patients. If you can't manage them, then if they've had valve, I would go ahead and do that. If they've had thoracic surgery, personally, I would get a thoracic surgeon involved with me and still go ahead and dissect things out in the chest. I don't think that's a limiting factor because the pericardium hasn't been invaded, so the appendage should be accessible. It's just a matter of taking care of the adhesions that are present within the chest cavity, and that should be able to be done. It's more the mammary being draped over or other grafts that get in the way that would concern me and make it limiting.
Yeah, thanks. Other questions out there? There must be some other questions.
You know, as I was saying yesterday, this meeting, from the standpoint of the surgeons, this is not a sexy operation, but it's terribly gratifying. When you see the patients who had this problem and are satisfactory. I have one particular patient who was a pacemaker rep, and I knew he had AFib and had problems with AFib, and I keep seeing him in the hallway and asking him, when are you coming for this procedure? And he's listed himself as number 50. It was number 50 on his chest, because he number 60, he was the 60th case we did. But you know, he's got to be at least 5 years out right now, and doing great. Anecdotal stuff, but you know, I think many of our patients were just pleased that they don't have atrial fibrillation anymore. And it's, you know, really, it's always hard to, you know, tell the public or non-interventionalists that this isn't a big deal. I guess from the standpoint of open heart surgery, it's not a big deal. So that's the perspective that you know, I take as a cardiac surgeon. It doesn't mean you can't run into problems. You know, I think it's a fairly safe, it's a very safe procedure. It's done on a direct vision, and you know,
Many patients with chronic, persistent, or long-standing AFib, of course, have remodeling of their left atrium, both atria actually, but left atrium gets particularly big. I noticed there was an upper limit sort of in some of these studies. Do you consider, is there an upper limit of size, or you know, when do you turn somebody down from your point of
you
view?
know, I've not used that as a criteria. I'll do it. I have to tell you that when I do an open case and I see a 10 centimeter left atrium, I'm really turned off by the concept of doing a MACE 4 procedure on them, because I have done it. But when I do, I cut out a fair amount of the left posterior wall of the left atrium to try to debulk that. So I wouldn't say I'd turn down somebody who's 7 or 7.5 or 8, but I think we have to be realistic as to what the chances of having a satisfactory result are. But it's not, you know, it's not something I would rule out.
That was interesting presentation. Thank you. So when FDA approved these procedures, what they are looking for, what is their criteria to approve this kind of procedure?
Well, the procedure was approved for long-standing persistent atrial fibrillation. It was approved based on safety measures and outcome measures. As you can see from the standpoint of results, they were about 20% better than the outcomes with endocardial ablation alone. So that was the basis of the approval.
Thank you.
Any other questions?
How long does the procedure take?
You know, so it depends on how many lesions you make. Each lesion takes 90 seconds to do. You can't make the 90 seconds go any faster. I have to say that probably in the first half of the cases I did, I would average about 50 ablations per patient. I think more recently it's been closer to 40 for whatever reason. I can't tell you, maybe because I'm using the electrogram more. We were having initially some issues with being able to record, and I know there are lots of burns that I go over because when I was depending totally on visualization, sometimes you burn, but you just don't see it on the epicardial surface. And so the feedback's important. I'm pretty aggressive about going over the right side, try and get the right side pulmonary veins. I have no illusions to think that I'm getting transmural there. My philosophy is the more I can do on the epicardial surface, the easier it is to reach transmurality. Because particularly that area on the right side has a tremendous amount of fat around the pulmonary veins and in the septum between the left and the right atrium. And I try to go on the left side anteriorly as well. There are times I'll actually see the burn go all the way up to the base of the left atrial appendage. So, you know, it takes probably about 2 hours to do the surgical component. But when I
With
teach
the
it,
recovery, I'm sorry.
recovery's a 2 day, so I should tell you, we do have a routine. It has evolved. We leave a pericardial drain in place. I inject the Kenalog solution the following day to bathe the posterior wall of the left atrium. I'm not sure what, now that we're routinely doing the appendage, how much of that stays there. There is a trough, so I would think that there is some fluid there. We keep them on colchicine for a month. And when we started with the appendage, we noted that there was an increase in pericarditis. So we added 6 doses of steroids while they're in the hospital intravenously. And we haven't had any pericardial effusions or pericarditis to deal with. The patients usually go home on the 2nd day after surgery. We start anticoagulation the night after surgery. If there is a little bit more oozing, then I would like to see, I may start them on IV heparin where I can control that more readily just to make sure that there's nothing of any significance. And then transition them to whatever they were on before, either DOAC or Coumadin, depending on preference of the physician. And they usually go back on their antiarrhythmic agent that they've been on before, or if they haven't been on, you know, my personal preference is to put them on amiodarone for 3 months, but this is a discussion with the electrophysiologist as to what we will choose for the patient. I see them, I was seeing the patients 2 weeks post-op. The EP was seeing them 4 weeks post-op. At 3 months post-op, they get an echocardiogram and get seen again by EP. I'm a creature of habit that I like keeping contact with these patients for my personal feedback in addition to EP seeing them. So I would then see them on a yearly basis. And EP would see them after 3 months, 6 months, and a year.
Fantastic. Well, I see it's now 1 o'clock, so many of us have to get back to patients. But I want to thank you, Dr. Jacobowitz, for accepting our invitation and enlightening us today on this very interesting technology and one that we hope to bring to Cooper very soon. And so it was very great to welcome you to Cooper. Thank you very much.
Well, thank you. It was my pleasure.
Okay. All right, folks. Our next grand rounds will be back on Friday in March, and we have an outside speaker for that one as well. I'll send out more announcements. So thanks, everybody. Great day.
You're still in the temple.